Hello, everyone. Thank you for being patient with us. We had some technical difficulties, but here we are. I'm Jesse. Welcome to our second COVID Decoded live series. We're super excited for Raw Talk's first virtual live event, so thank you all for tuning in. Before we begin, we'd like to acknowledge the land on which the University of Toronto operates. For thousands of years, it has been the traditional land of the Huron-Wendat, the Seneca, and most recently, the Mississaugas of the Credit River. Today, this meeting place is still home to many Indigenous people from across Turtle Island, and we are grateful to have the opportunity to work on this land. For those of you who are new to the podcast, Raw Talk is a graduate student-run show about the meaning we find in science and the people who make it happen. We talk to scientists, students, clinicians, and the patients behind the scientific innovations and advances happening here at U of T and around the world. Check out our website, linked in the description, for access to all of our episodes. You can also listen to our podcast wherever you get yours. Now, if you're anything like our team, over the last few months, you've been probably trying to wrap your head around the scale and impact of the current COVID-19 pandemic. The rapid pace of discovery and evolving public health situation have made it hard to keep up. So, as we adjust to the new normal, it's clear that the current pandemic has far-reaching effects on health, research, society, and even our planet. So we've decided to turn our annual live event into a live stream series all about COVID-19. Helping to support this project, we'd like to thank our Pillar Affinity sponsors, TD Insurance and MBNA. Without their support, this series would not be possible. Check out the link in the description to learn more about preferred insurance rate and credit card rewards for U of T alumni. Over the next few weeks, we'll be talking about COVID-19 research and the impact the pandemic has had on our everyday lives. Last week, we sat down with Dr. Karen Mossman and learned about how coronaviruses infect human cells and cause disease, and why understanding those mechanisms is key to designing treatments and interventions. For today's live stream, we'll discuss the basics of mathematical modeling, the special considerations of COVID-19 modeling in the Canadian context, and how lessons learned from these data can help inform public interventions and the next steps. Joining us to share their expertise on these topics are Dr. Sharmistha Mishra, an infectious disease physician and mathematical modeler, and Linwei Wang, senior data scientist and epidemiologist, both at St. Michael's Hospital. Please join me now in welcoming Dr. Sharmistha Mishra and Linwei Wang. So, as an epidemiologist and as a mathematical modeler, how do you both arrive at your current positions? Maybe Linwei, you can start us off.
Sure. Hi, everyone. I'm Linwei. I studied public health and epidemiology in the University of Alberta. So I was receiving training in both epidemiological and biostatistical methods. I started really interested in working as an analyst on longitudinal type of data in the field of childhood cancer, both as my master's thesis as well as some of the research projects I involved in. So after graduation, my passion was to become a research analyst to support various types of epi data. And I landed a job as a biostatistician at the BC Center for Excellence in HIV/AIDS in Vancouver. So working as a biostatistician with epi background, I was fortunate enough to be involved in various of epidemiological studies and applying biostatistical methods to understand the health service research as well as the treatment outcomes of HIV/AIDS. And I was part of a health economics research unit. And the team back then was doing a study, NIH-funded study to evaluate the impact of different HIV interventions in 6 US cities using a HIV transmission model. That was the first how I got introduced to the transmission modeling. And I started off by involved in evidence synthesis and model parameterization for a deterministic compartmental HIV transmission model. And gradually, I got to learn about different model structure and started some hands-on model analysis. So when I moved from Vancouver to Toronto, Dr. Sharmistha Mishra's mathematical lab becomes a natural and a greater choice for me. So I get to work with a group of brilliant scientists and analysts, modelers, epidemiologists on various projects. So in the pre-COVID era, I was working on research focusing on to understand the sexual missing patterns among men who have sex with men in Canada, as well as applying HIV transmission model to evaluate the impact of sexual missing patterns such as serial sorting on the impact of HIV intervention strategies such as PrEP. And since the outbreak started in March, our team, including Sharmistha and myself, have been working on COVID-related projects, including we're trying to use a deterministic COVID transmission model to estimate the healthcare surge need in hospitals in the Greater Toronto area, as well as using the surveillance data of COVID, trying to do some epidemic appraisal of the COVID epidemic in the Greater Toronto.
Excellent. Thanks so much, Linwei. And I know there were maybe some words we're familiar with there, but we'll circle back to make sure we define some of those too, because yeah, I know it's really complicated, and that's where we're excited to help you share your expertise here. Thank you. So Sharmistha?
Thank you, Jesse.
So the question of how we went into mathematical modeling in particular for myself, really coming from an infectious disease clinical background, and having the opportunity and the privilege to work and support outbreak analyses and outbreak investigations. The thinking that is involved with trying to understand the logic of how outbreaks evolve, how the mechanisms of transmission at a population level is what really drew me to working on infectious disease modeling, going from sort of the clinical, the patient, and sort of what we see to understanding how that evolves at a population level. So really for me, it was the light bulb that hit when I think I finally kind of really understood what herd immunity was, as well as heterogeneity and variability in risk, and what that means for herd immunity is kind of what drew me to transmission modeling.
Awesome. So can you walk us through, maybe Linwei, you can tell us a little bit about the importance of epidemiology as a science in the context of a pandemic?
Sure. I think it's a very broad question because as epi involves different areas of research and different researchers been working on their own different fields. So a rough, very chronological, or actually very rough, is let's think about even before the start of the COVID pandemic. Each country and region have the public health surveillance system in place. So it speaks to the outbreak detection in terms of the epi's role in the pandemic. And since the outbreak started, there is field epidemiologists who actually went into the community, talked to the people who were diagnosed, trying to understand some common between the cases. So that's the start of the outbreak investigation. And even during now, also contact tracing, trying to find the epi links between different cases, really informed our understanding of the routes of transmission. And moving forward with all the data collected either by the surveillance system or by the interviewers who went into the field, quantitative epidemiologists have been all hands-on with the data. And we're trying to understand the aspects such as what's the epidemiology of COVID, like, for example, what's the incubation period, serial interval, all the way to what's the full spectrum of disease severity of COVID, what percentage requires hospitalization, and what has outcomes such as case fatality, etc. And moving even further with more data come in, and it really speaks to actually, as an epidemiology, it's a study to describe the distribution, also determinants of health states. So then we're trying to identify what's the risk factors, which subgroups are at a higher risk, and in terms of the getting the COVID infection, as well as the outcomes, the severity. And so that's another perspective of how epi has playing a consistent role. And from another angle, it comes like intervention evaluation. And epidemiologists been working with methodologies in terms of like statisticians and as well as mathematical modelers, trying to using different approaches to evaluate the intervention. And one more thing is, I think everyone is interested in will be, so when is the vaccine come in? So this is a typical, the random controlled trial, which epidemiologists working with biologists and virologists trying to enroll and design the trials to evaluate the treatment effectiveness as well as potential vaccination. Yeah, so all the way from the detection to how do we control and promote the health of people. It's kind of all the root, it gets really to the root of the epi.
That was incredible answer. Yeah, so many more details than I was anticipating. Yeah, thank you so much. And then a similar question for you, Dr. Mishra. What is the importance of mathematical modeling in the context of a pandemic and obviously specifically COVID-19?
So, I mean, when we think of mathematical modeling, and in this particular situation, we're talking about transmission modeling. So models that account for, or specifically look at the mechanism or what we call sort of the population level causal pathway of transmission, the feedback loops from a prevalent infection to an incident infection, and sort of that instantaneous or what leads to nonlinear effects, essentially. That element nicely combines with everything that Linwei was just talking about with respect to epidemiology. So throughout the sort of, you can think about a data life history or a life course of data or a life course of epidemiology in the context of an outbreak, and think about where transmission modeling can complement either thinking about theory and fundamental insights. So estimates of the generation time or serial interval, incorporating that into a transmission mechanistic model to forecast what might happen, all the way to the intervention component aligned with these clinical trials to estimate the herd immunity component, the indirect benefits of an intervention, for example. So I think transmission modeling can kind of follow along that entire life course that Linwei was describing. So really working, in essence, as much as possible, hand in hand with epidemiology, with the biostatisticians, with virologists, with immunologists throughout that course.
Yeah. Awesome. And just so the audience is they may not have the same epi background, could you guys help me define maybe like incubation period and a serial interval, and also incidence and prevalence? Maybe Linwei, you could help us out there. Thanks. Because I think they'll come up a lot.
Yeah, this is really testing my textbook knowledge. Yeah, so incubation period refers to when the infection when the virus is transmissible. So it includes the period of subclinical, when the individual who are affected are not showing symptoms, however are still transmissible. And also the period where there is a symptom and there is infectionist. So that's the incubation period. And based on the literature, I think the commonly understood number is the 5 days about the incubation period for the COVID-19. And the serial interval speaks to when the two cases, let's say case A infected case B, and the time between when case A is showing symptoms to the time when case B is showing symptoms. This is all very important epidemiological features of COVID, because all of them together actually contributes to the transmission dynamics of the COVID.
I remember hearing actually that incubation or that serial interval can actually be negative, because in the case of COVID-19, there's so much variability in the incubation period that someone might transmit to someone else, but then that person goes on to develop symptoms before the person who kind of transmitted to the other. So I think that, as far as I understand, has kind of complicated a lot of the assumptions or challenged some of the assumptions that we've been making in these models. Is that right, Sharmistha?
Yeah, so exactly as Linwei nicely described, we think about incubation period usually from a clinical perspective, framed around when symptoms develop. So when transmission may occur prior to the onset of symptoms that are noticeable. So so symptoms that can be easily detected, that are not vague, for example. So when we have transmission prior to that, then we can get these periods of time where, just as you described, a person can become symptomatic, but have already passed on infection to someone else. And we have numbers like, yes, the average is about 5, but there's a distribution around that for all of these estimates, so they can overlap, and you can get these negative features. And the serial interval ends up being important because it's really a proxy for, in classic transmission modeling or epidemiological constructs we think of as generation time, the time from one person actually acquiring infection for the infection to be passed on to someone else, and that other person on average acquiring that infection. And so the shorter that is, the faster an epidemic can take off. And so we usually use serial interval instead of generation time because it's hard to know and observe, I should say, exactly when those infections actually occur.
Yeah. Awesome. So kind of changing gears a tiny bit, what are some of the insights that we've actually already generated from some mathematical modeling of coronavirus? Dr. Mishra.
Lots, I would say. There are things that we knew, like fundamental insights that were generated, prior to like the novel coronavirus or COVID-19, and that were applied to understanding specifically fundamental features about COVID-19, including the variability around the reproductive rate, dispersion around the reproductive rate based on sort of along those elements. Important aspects such as the potential contribution of pre-symptomatic transmission, combining both how the viral load during pre-symptomatic and symptomatic periods, as well as contact patterns, and sort of translating that into possible onward transmission. So the contribution of onward transmission from sort of the pre-symptomatic period, those elements have been quantified. Important insights, I think, that perhaps were known before, but were really brought to the forefront in discussions, particularly around the communication of it. The ideas of the important how much once you stop transmission and you get the reproductive rate below 1, the amount of time that it can still take for cases to actually go down, because we're waiting for those incubation periods and and serial intervals to sort of play themselves out, even though we've stopped a new acquisition at time X. So based on how many cases we have at that moment, that we still have a lot of effort to go, or time to go. The importance of heterogeneity in physical distancing, recognizing that even in an equation, when we say this is how much we need to reduce the contact rates, that the application of that or the implementation of that will vary in the population. And so we've learned more and more about how the saturation effect of herd immunity can play a role in that, but also in thinking about certain constructs where we may not be able to reduce contact rates, where there's a cap to that. And so what other interventions do we need to put into place? And then finally, the importance of, the pre-symptomatic transmission element, and therefore, what does that mean for the way in which we do contact tracing, and as well as the reducing the time from potential exposure to being able to provide the facilities the structure to be able to self-isolate well and safely. So I think we've learned several of those elements beyond specifically for COVID itself.
Okay, so changing gears slightly again, maybe even coming back to the origins here. Could you walk us through, Sharmistha, what is a mathematical model of transmission? I know it's a huge question, and maybe you could just focus on a certain type that you've been using for your research here.
So a mathematical model of transmission, compared to, say, other types of mathematical models that are also used for forecasting, that are also used for prediction, for example, so statistical models, or sometimes they're called phenomenological models. A mechanistic transmission model, essentially at the heart of it, has a feedback loop between a prevalent infection and an incident infection. So in essence, some people think of it as each case is a risk factor for another case. It's that interconnectedness that is happening either instantaneously and or within the system of the model. And it can lead to indirect effects that happen as a result. And because of those interactions and contacts, we get these unobserved or effects of things like herd immunity. And so a transmission model captures that in a way that's dynamic. So it captures that feedback loop, and it mechanistically captures this effect of herd immunity or indirect benefits or indirect effects, whereas other models that are statistical models or phenomenological models that can also be used for similar questions as mechanistic transmission models, particularly around forecasting, do not. And as a result, a mechanistic transmission model, because it explicitly says this is what the causal pathway must be, we have to have a bunch of prior knowledge on the biology or the natural history of the particular pathogen, on some understanding of how people come into contact with each other, whether we stratify that or we kind of assume we're all going to kind of, randomly mix and bump into each other like Brownian motion, right? So we have to a priori put those have thought through and put those mechanisms, which can be considered like conditions of the model, so that anything we do with the model is conditioned on the mechanism or the population level causal pathway that we have pre-specified based on knowledge that we have from before.
Yeah. Awesome. Thank you. And similarly, kind of, actually, Linwei, did you want to add on to that at all? Yeah.
Yeah, sure. I think I come from like a very my scope of view when I work on the deterministic compartmental HIV transmission model and now the deterministic COVID model, transmission model. So to me, as Sharmistha mentioned, it's a set of rules predefined that requires expert knowledge. So you build in like what's the different states of the model. For example, you will have susceptibles, you will have like infected, and for infected, as we mentioned before, to capture the disease severity, then there will be subclinical components, and then individuals who are infectious, and then the clinical component, individuals who were diagnosed and moving to hospital. So try to visualize kind of a map of the movement of disease severity as well as the movement of the clinical treatment and outcome. That's kind of when we draw out the structure of the model. That's how I try to envision. And then it comes to the component Sharmistha mentioned is how different individuals in different components actually contact each other. So it says to like without sufficient data, we assume the random mixing type of assumption in the model. And so I found it that without sufficient data, especially at the early phase of the outbreak, when we don't have observed data on how the cases played out, mathematical model, especially the mathematical infectious model that aim to forecast plays a huge role, because without the data, you can only rely on what we understand about the rule of transmission. So then it helps us to predict with certain uncertainty. And versus statistical model, some of the curve fitting methods, I think it really requires the observed data curve. Then you're trying to create a model with parameters and fit to the curve, and then you project into the future. So, and another component, I think some of the difference is they are actually interrelated. As a graduate student before, like coming from epi background, when we work a lot with statistical models such as, we're trying to estimate the odds ratio of certain factors in terms of the outcome. So how does that actually correlate with the mathematical model? After I've been working on model parameterization, actually, indeed, a lot of those estimates, such as odds ratio, for example, what's the increased case fatality among individuals of older age group, we can apply a logistic regression to estimate, or Poisson regression to estimate that relative difference. And that relative difference then can be fed back into mathematical modeling in terms of model parameterization, trying to capture the heterogeneity in terms of the prognosis of the COVID virus. So that's kind of my understanding of the model and how it relates back to some of the statistical modeling.
Yeah, yeah. And just to, for the audience, what parameterization actually might look like, variables that we may be interested in include things like the sizes of each of those risk groups, which may or may not be fixed over time. People might move between risk groups, and there's kind of a rate of movement that we might want to estimate. And then, like you said, we may have exit from a certain risk group, and we're not necessarily sure on the exact rate, but we're sure on the relative rate between those two groups, which is literally coming straight from epi terms. And we could kind of fix that and allow like the overall rate to vary or something like that. So basically, most of the parameters tend to be rates, I think, that we're estimating when we say parameterization. Anyways, you kind of already started to touch on this when you talked about homogeneous mixing. So could you tell us some of the other kind of assumptions that tend to get baked into these models, Sharmistha?
Yeah, I mean, probably the largest assumptions are, I should say, the conditions under which we're doing the modeling. So we have to answer questions a priori on, is this a population that is closed? Is this a closed system? Or do people kind of enter and exit the population? Assumptions, and Jesse, you mentioned this on, do people move between risk groups? So do they come in and out of sort of demographic states? So not just aging, for example, but for example, if we're thinking about shelters for persons experiencing homelessness, sort of there's contacts within the community, and then so that maybe going into the shelters and just for the night versus contacts only within the shelter system. And usually all of these always reflect back on who is contacting whom. And so what are the potential ways in which transmission may occur? So when we these are the conditions that we have to lay out. So the closed system, the coming in and out of demographic states, because the proportion of the population that is susceptible really is that element of herd immunity. And sort of, the proportion that are susceptible, especially if there's turnover and, new susceptible individuals entering into a high risk or higher vulnerability environment when we haven't changed anything else, kind of continues to potentially be a little bit of like the fuel but for the fire. So that's another one. And then lastly is exactly the mixing, the who comes into contact with whom. And then lastly, the typical things that happen with any study or epidemiology, which is what is the time frame of the analysis? Where are we now? Are we at a growing point in the epidemic? Are we kind of at a flat point? Has the epidemic not taken off yet? And so are we just estimating what might happen if there was introduction of an infection? So then those are all other conditions under which to lay bare the answers to our questions.
Awesome. Thank you. Briefly, since it's come up a couple of times, can you quickly define deterministic versus stochastic, and maybe compartmental versus individual based, if that's Sharmistha, yeah. Thanks.
I was going to say, Linwei, do you want to?
Oh, sure. Yeah.
She's pointing it back at me.
Okay.
So deterministic versus stochastic. So really, one just tells us a little bit about what are the average properties. So if we're thinking about these compartments or health states on average, versus, hey, I'm going to look into like all the random chance that might happen. So even though I might have a bunch of average features, chance plays a role. And so we often think of them as like epidemic or outbreak realizations. So, on average, we might see the same thing, but actually what we'll see will take into account a bunch of random chance with respect to, for example, whether an infection occurs, which is an average property in my deterministic model, versus there's some chance element to it, even for the same rate for the stochastic model. And then the other one you mentioned is compartment versus sort of individual based. And that's really about whether or not we sort of average folks out so that we have health states that take a group of us together versus simulate out every single individual and the attributes or properties around an individual. And it comes, there's a bit of a spectrum there where we go from kind of averaging things out and subsuming a little bit of the heterogeneity all the way down to simulating every single person, which doesn't mean simulating every single person to reproduce reality, but rather the properties of reality that we observe. So even an individual-based model is still a simplification of actual reality.
Yeah, Yeah, because it's impossible to capture everything.
Yeah,
Basically.
and it's not the question that we're trying to answer per se. Exactly.
Yeah. Okay, so if we imagine kind of two aspects coming into modeling, one of them being our assumptions, our understanding of the problem, and maybe certain equations that maybe we need parameters for, what are the data that help us actually build those models? And where do those come from? Maybe, Linwei, you could start us off.
Sure. So data and the mathematical model structure actually go side by side, and one informs the other because, like, for example, when we think about different compartments, I'm talking about from like a compartmental model perspective as an example. And if we were to have different compartments, such as susceptible and people in the subclinical state and infected and those who are hospitalized or on ICU, then we do need to quantify the number of people in each state or the rate of movement. And so that's one part. And so it covers population demographics, which can come from the census of data. For example, our model of GTA, we need a census of the population size and the population growth of the GTA population. And in order to replicate the transmission dynamics, we need the data such as epidemiology features. So as I mentioned earlier, we need literature review to get the information also what's the estimated serial interval, mean and the distribution, as well as what's the duration of incubation period. So those are the data that speaks to the epidemiology of the virus. And then the other data comes to the clinical features, percentage of cases that's been hospitalized and the severity of the disease. And lastly, when we pull in all the things into the model, we want to validate or check whether the model produces the so-called reality. So which some of the features, we also call it calibration targets, including, for example, what's the diagnosis rate per capita, proportion diagnosed per capita, and what's the time series of the number of deaths among those who are diagnosed. So those are the type of data we are looking for. And for where the data is coming from, there are several routes. For example, the census data for the population demographics. And the key part will be the surveillance system. For example, in Ontario, it was called the IFI, the Integrated Public Health Information System, which captures all the confirmed cases and probable cases in the province of Ontario. It's a personal level data, so we can get information such as what's the age, sex, and also where individuals reside. So we know we can attribute the cases to different regions, and also including whether the case have been in contact with already diagnosed case. So it comes to the contact tracing elements in the data. And in addition to that, we will have data such as the health administrative data in Canada, which includes, for example, the laboratory testings. In Ontario, it's called the OLAS, Ontario Laboratory Information System, which captures all the lab orders and the results, and of course, including the COVID tests and the results. In addition to that, we have data such as ED visits. So ED triage data, which captures potential suspected cases of COVID, which supplements the diagnosed cases. And moving forward, besides the ones that's being routinely collected, we also have data collected specifically during the COVID pandemic. For example, the Ministry of Long-Term Care has a long-term care home case checker, which checks at the long-term care home facility level what's the aggregate number of cases among long-term care home residents, what's the death, as well as that among staff. And so those are also pieces of data that's either been routinely collected or we start collecting during the epidemic. And on top of all this data, there are literature out there. And I think that's critical in two aspects. One is at the early phase of COVID outbreak, even though we don't have data for, let's say, Canada or Toronto, Ontario per se, lots of modelers still putting out models for the forecasting, which is heavily rely on what has been happened in other countries such as China, South Korea, Singapore, who had early waves of the outbreak. And so literature is another component. When we don't have the region-specific data, we have to generalize by learning what we've learned from other epidemics.
I have to say, in reading the literature, I've been so impressed with the level of open source sharing of both code and preprints. It seems the pace of this has been, I mean, it's hard to stay on top of, but it's been a really Herculean success with all the sharing and knowledge translation. Yeah. Sharmistha, anything to add to that?
No, that was fantastic. And I think just 2 points. And the first is when in an outbreak setting, data are evolving, and I think what we've learned is how different this is than some of our HIV work, for example, where infection is endemic, and so there's a history of surveillance systems and data systems. But with COVID, data are emerging, and as we learn, things are being adapted with respect to data coming in. Which also means that it's important to think about validating the estimates and or cross-checking the data themselves as well. And not just the model. So occasionally it's like doing a meta-analysis. Like there are multiple sources of data. And what I hope came through from Linwei's description is that as transmission modelers, we're usually not working with one data source. Yeah. We're usually working with multiple. So the data synthesis component, including often statistical modeling that generate priors of relative risks that we then need to calibrate to, for example, are all a massive element of transmission modeling. Particularly data-driven transmission modeling, when we move from sort of fundamental insights to intervention modeling and things like that. The second point, and to what you raised, Jesse, is I think we have all been impressed with the amount of open data sharing, but also code sharing. So I think this reciprocity of sharing of knowledge, of tools, and I think has been fantastic. It has also raised, I think, the level of scientific rigor and discourse around things like, oh, hey, serial intervals are negative. What are ways we can address that? And then sharing those tools, which is something that you've done, Jesse. So I think that just putting in a plug out there. And similarly, I think of the bias analysis. So Linwei's done a lot of bias analyses, for example, for our GTA modeling, and sharing that way across the board and making that open access. So I think that element I've really felt as part of a wider community of data and modeling and interrogation of our work in a really positive way.
I remember reading an article about some code from Imperial College. I think they said it wasn't pretty, but it was all correct. One of the models that they had open source. So yeah, that's really important.
And especially when we're working fast on something, if anything, this is a great way to put it out there and be like, hey, someone check, and additional, like a community of people sort of checking and then looking at it. And it's the code, but also it's the decisions we've made, right? So it's those assumptions and the conditions and the bias analyses of the data ahead of this that I think is also really important for us to be very transparent about.
Yeah, definitely. We had all sorts more questions before. At the end, we do want to say 15 minutes for questions from the audience, but we have about 10 minutes or 5 minutes before that. So I'm just gonna give a quick read here. So do you want to talk a little bit about some of the special considerations for data that have been used to parameterize models of COVID-19 in GTA and Ontario? Kind of more specifically about Linwei?
Sure. I think we've partially touched base on that from what Sharmistha been talking. Since, for example, one thing I think it's recognizing the fast evolving of data. Every day we can see data changing, new fields come in, and also the patterns change given the different time points. So it's to adapting to the faster changing pace and work with what we have. And second is, I think it's upfront, like what is observable and what is not. So I think it brings back to the point you were trying to raise before, is the incidence, the true incidence versus the observed diagnosed cases. So for example, other surveillance system could capture the diagnosed or detected cases. And what's out there not being captured, and what's the challenging part is, so what's the actual population that's actually being infected with COVID-19? So this comes to, when we look at the data, we bring in what's the limitation in the data, then how do we address it? For example, in this aspect, in terms of how do we capture the part that's been not diagnosed, there are two potential ways. One is there are literature out there using, for example, study samples among those repatriation flights or cruise ship, where you had the opportunity actually to test everyone and document what's the proportion that actually have symptoms versus not, to have a sense of what's the ratio of diagnosis in certain population and in certain region. And second will be to capture what's the potential susceptible cases. So in addition to the surveillance system ISIS, we also rely on, for example, at the ED data, trying to see at the ED triage or the ED visits, what's the size of visits that has susceptible COVID symptom, to get a gauge of what's the part that's missing out there. So that's the second part. And another part I would say is closely related to the time dependency in a lot of, for example, the intervention. For example, the testing patterns have been keep changing given the testing guidelines. So being able to, in the model, to capture the different testing rate over time in response to the change in the testing policy or guideline is very critical. And
because you could imagine that certain populations who are prioritized for testing when tests are limited are expected to have maybe higher prevalence, higher proportion of cases. And then over time, as we scale up our testing, we're testing people who are less and less likely to maybe have, but at the same time, the epidemic may be growing. So yeah, it's very complicated. Sharmistha, anything?
No, just that I think bringing home the point about how important it is to sort of look at the data almost all together, sort of that descriptive epidemic appraisal, starting to pull some quantitative elements out of that, and then thinking about how our transmission model, whether we use that as a prior or calibration targets, really are combined. So that, and again, just being really upfront in our, what have we included as sort of the change in testing patterns and the reasons for it, because as you said, there's sort of the per capita rates and the positivity rates will change according to the criteria that we use for testing, or the surveillance point prevalence stuff that we might have done, for example, in long-term care facilities and so forth.
Okay, and last question. I know we need to get some audience questions, but last questions. Sharmistha, I know a lot of your work, especially around HIV, has considered risk heterogeneity and the importance of that for understanding the dynamics of an epidemic. So can you talk to how that's been influencing the COVID-19 epidemic and the importance of it, capturing it in the models?
Thank you. And yes, I think that was part of when we first started some of the COVID work. It was really in response to some of the hospital needs. But where we went with this scientifically was drawing from the fundamental principles that we use in HIV transmission modeling, which is really thinking about heterogeneity in acquisition. So my risk of acquiring, heterogeneity in onward transmission. So what are the conditions, the environment I'm in that may lead to super spreading events or conditions, and onward transmission. So not just a one-time thing, but potentially onward transmission. And then heterogeneity or variability in severity, that might be reflective of age, comorbidities, and others. So, but it's those first two elements, and particularly that middle one, the heterogeneity and onward transmission, that I think is becoming more and more important. It's becoming evident in our data. So it's becoming evident in how the epidemic has evolved, thinking about congregate settings, whether fixed or due to social constructs that limit physical distancing, for example, or limited with respect to infection prevention control practices. And supports a priori or before the outbreak, and so that led to increased transmission. So thinking about those elements, and particularly that level of heterogeneity with onward transmission, and because that will influence not just forecasting down the road, particularly when we get closer to an R of 1, we really fluctuate according to sort of these heterogeneities. But second is just from an intervention perspective, sort of this one size shoe fits all approach where we just reduce one element of our equation and reduce contact rate could apply very differently across if there is actual heterogeneity, both because the baseline risks might be different, but also because access to interventions and testing and supports might also be different. So heterogeneity in risk, heterogeneity in access or inequities really could sort of continue to drive transmission, which we might miss out on if we don't think about that in our transmission model. That's not to say every transmission model has to have it, but if one of our questions is, what role does heterogeneity play? What interventions? How do we distribute interventions? What do we need to think about for protecting vulnerable populations or facilitating supports so that we reduce transmission across vulnerable populations and settings? Then we need to be thinking about that in our transmission model mechanistically.
Can you give us some examples about maybe populations who are more vulnerable or other spaces that people might be living in that are contributing to increased kind of risk?
Yeah, so what we've learned so far, and again, not interestingly, but we sort of knew this from prior to COVID-19 as well. We knew this with other respiratory viruses that had similar transmission dynamics. So facilities like long-term care facilities are more vulnerable spaces, both for residents, potentially as well for staff. And care workers. We know that work facilities, particularly where physical distancing is challenged, and essential workplaces have become settings that are more vulnerable, again, from a combination of challenges perhaps with physical distancing at the workplace, but also baseline infection control supports. Prior to that, similar with our long-term care facilities, shelters, and vulnerabilities of persons who experience homelessness. And for example, we saw in GTA that there was an increased risk, but then many facilities had a priori already started putting in supports, knowing that this might be a vulnerable situation or setting. So we're seeing that. And then also when we think of sort of the outside of congregate settings and we think of community transmission, it's really thinking about how they're linked with essential workplaces or congregate settings. And so what are some of the social determinants of health that limit physical distancing, for example, within households or multi-generational households or older apartment buildings and physical design of structures. So there's heterogeneity across the board and when we think about it mechanistically, it comes down to what are vulnerabilities with contact rates that limit physical distancing? What are vulnerabilities with respect to access that play into those elements?
Awesome. Thanks so much. Yeah, that kind of wraps up the questions that I had time for, that I had planned. And now we'd like to go to some of the questions from the audience. So just give a quick read here. So one of the questions is, you mentioned herd immunity. Can you expand on herd immunity as it relates to COVID-19, and what percentage of the population will need to be immune? And are there some models that kind of predict when this will happen? I'll let you guys decide who would like to take that.
Do you want me to start with that, Linwei? I'll just. So a big question. So first, when we think about herd immunity, we're really thinking about how contacts may occur between somebody who could pass on the virus with others in a way in which the others are no longer susceptible. So that might be because they've already been infected and now have a certain degree of protective immunity. It might be because they've been vaccinated. It might be because we actually essentially cohort or bubble ourselves a little bit so that we just reduce who I might come into contact with, for example. So it's really what has happened to the proportion of the population that would otherwise be susceptible. And so by reducing that, even if I could pass on the virus to someone else, I may not, just because of who I'm coming into contact with. And so that's the pure element of sort of herd immunity. But of course, as you can imagine, there's a lot of other things that can act as well with that. For example, things like, wearing a mask and so forth. So, and then when we think about herd immunity with that concept, so it really comes from the vaccine literature, right? And so one thing I would think about promoting is, and it's come out in 1 or 2 papers now, is we think of herd immunity in terms of its language around vaccine, but to perhaps think about this as shield immunity to remove some of the connotations that come with herd as well. So it's come out in the literature, and it's kind of this nice idea of thinking about, sort of how do we sort of shield a susceptible population, for example. Do we know what the actual estimate of that needs to be? And that will come down to, in whichever model estimates it, 3 questions one must ask themselves. 1, is it a closed population in which susceptibles are no longer entering, or they're actually entering the population? So is it a closed population or not? Second, the model that estimates it, ask ourselves, are we mixing all homogeneously to get all at the same time, or are there pockets of higher, more vulnerability, or pockets of risk, for example, or even whether it's geographies, whether it's physical spaces, congregate settings, for example, or our physical networks. Okay, so that. And the third element is who's being removed from our population. So, whether they're moving out or they're dying at a disproportionate rate. Okay, so all of those elements contribute to the proportion of susceptible within one's physical network. And so that's why the estimates of herd immunity that is required to control the outbreak will be different based on, 1, the underlying reproductive rate in the population, which is all about population structure as well as contact rates and heterogeneities in those. 2 is if the model captured all of those, or if it just sort of assumed homogeneous mixing. And then a third, I went backwards again, is that what happens to susceptibles as they enter in or not. So I can't give a number, but there are ranges across studies, and I would encourage us to think about the conditions under which those herd immunity estimates were generated.
Awesome. Okay, and a question here for you, Linwei. How do we make prior decisions or leverage prior knowledge for a infection like SARS-CoV-2, which is so new? So how have we come up with some of those prior distributions, or where do those types of assumptions are coming from? Oh, I think you're muted.
Yeah, I think I come from a combination of study. One is, I think, relying on the prior knowledge. It's like we have other virus that have similar structure, right? For example, I think that at very early on, people were closely trying to compare coronavirus to what's happened like in terms of SARS, and trying to compare and estimate what's the R0 of SARS, and with data going in, the R0 of coronavirus. So that's one. And second is, I think virologists may speak better, like in terms of like how the virus features, biological features, and transmission mechanism. And I think one thing that's often a preset rule is, for example, in the type of virus transmission model, the SIR type of model. So this is the prior knowledge. So we know the susceptible compartment, the infected compartment, and the recovered compartment. And those are the prior knowledge. And the second is, I think it's, as Sharmistha mentioned, it's an iterative process. So we start with something simple, and at the beginning of the model fitting, we were literally calibrating to what has happened in Italy and in Hong Kong, and trying to select our model fits using those constraints. And now, with the data collected locally, we will calibrate our model to the observed data in the Greater Toronto area. So I think those are the few aspects.
Awesome. Anything to add to that, Dr. Mishra?
No, just that the prior knowledge, particularly, or prior knowledge, whether we call it knowledge or actual priors, sort of like actual priors in the model with estimates at the when an infection is emerging is very important. And there was we know a lot from how other respiratory viruses are transmitted. So even when we don't know exactly how this will play out, so considerations of whether the E period or the SE part of this was important. How quickly we needed to know about pre-symptomatic transmission. So some folks use sort of SARS as the example, and others use influenza and said we don't know yet, but here are the two extremes, for example. So I think that is a really important element, and that means having the infrastructure set up so that when something emerges, people are ready to work on this or already have been, and can quickly adapt versus sort of scrambling to. So that's where the prior knowledge and work comes in.
Awesome. We don't have a ton of time left, but maybe one other question from the audience here. With the global nature of the pandemic, has there been a need for new modeling algorithms or new methods that scale in terms of that global scale? I'm not sure if it's something you've necessarily worked on, but has that emerged?
It's not something we've worked on specifically, but there's definitely the sharing of tools and approaches and solutions to some of these challenges. When we're thinking about scale, there definitely, in terms of, is the question sort of moving from sort of doing local to international, kind of global level modeling? In many ways, I feel like it's been the other way around. Sort of, we've gone from more like international, national, provincial scope of questions to now starting to become more granular at the local level. So I almost feel like it's gone that way, driven to some extent by local like heterogeneity and local context. So I feel like that's how it's occurred from a question perspective, but that the similar models are being used at multiple levels.
Right. Awesome. And then, so last question, since we are basically out of time or like in a couple of minutes. So what's next for you? What do you see to be the ongoing role of modeling in the continued response and epidemiology? Sorry, in continuing to address this response. Linwei, do you want to start us off?
Sure. As we've been mentioning before, like the epi is really the study of the determinants of health states. So I think during pandemic, we kind of learn it in a backwards way. When data come in, we're trying to understand which subgroups are at higher risk and what are the social determinants, the biological, demographic, economical determinants of health. And I think as epidemiologists, it's a critical part of study. I think working on the current determinants of COVID risk and outcome will actually inform us to actually enhance our surveillance system in a way that we can feed back the knowledge to how we design our surveillance system to start with, which as a field we should routinely collect or to incorporate, so to be prepared for the future modeling and intervention and the prevention of other diseases.
Awesome. Dr. Mishra?
I think it's I think next steps for transmission modeling would be to build on exactly what Linwei said. For us, it's to move forward with understanding the causes and contributions of heterogeneity and risks at acquisition, onward transmission severity, and evaluating our interventions. What worked? How did it work? Where did it work? For whom did it work? And for whom did it not work? And sort of starting to uncover some of those with the transmission modeling moving forward. And then incorporating that within the bigger picture. So we're sort of just one part of the elephant, essentially, when we're trying to understand the causes and consequences of the COVID epidemic on our society. And so starting to figure out where our transmission modeling falls into the bigger picture, including some of the unintended consequences, or not the unintended, but perhaps the negative consequences of the control measures that we model out that we don't measure perhaps in our model per se. So starting to incorporate that with other groups that are working on that, for example. So I think that's where we're headed next in particular. and I would and more open data, open code, open source code sharing of knowledge, I think, is where we're moving forward as a community.
Yeah, we talk a lot about paradigm shifts, and I think hopefully that's one of the enduring ones that comes from this, unfortunately.
Yeah.
Okay. Thank you so much for joining us. I think we'll have to call it there for time, but we really appreciate you guys taking the time out of your super, super busy days these days, and that'll wrap us up. Thank you so much.
Thank you.
So it's been an absolute pleasure. To learn more about the work being done at the Mishra Lab, check out the link in the description. And also, you could check out episode number 25, where Dr. Mishra talked about her research on STI and HIV transmission. Coming next in the series, we'll be talking about mental health outcomes of the pandemic with Dr. Rima, Styra, clinician investigator at the University Health Network, and Donna Alexander, social worker at the CAMH Center for Addictions and Mental Health. Make sure to tune in on Wednesday next week, July 8th at 3 p.m. to hear more from them. In the meantime, check out our Frontline feature on our Instagram at Raw Talk Podcast, where we're profiling individuals working on the front lines of the pandemic. And finally, you can support our show by using the affiliate link on our website and in the description below. Thanks again for tuning in, and until next time, keep it raw.